It's an honor to be here today. I'm kind of new in this role. I've been working with Dr. Lee for like 2 years now, and over the past year I've been his research fellow in the sarcoma clinic. I can tell you that probably most of you know about GIST way longer than I do. I've recently completed my training like 3 years ago, and now basically for the familiar faces, I'll leave the sarcoma clinic in the next 2 weeks. So yeah. And today, my presentation will be split into 2 main parts. The first part will be the MDT process, and the second part will be the recent clinical trial updates in the GIST population. At any point, if you have any questions for me, feel free to ask. First, I'll start with brief introduction. I have no disclosure for this presentation. First, I'll start with a brief introduction about GIST. What you guys might know is that GIST arises from like the epithelial parts of the gastrointestinal tract. The most common site of a GIST is the stomach, and there are other GI sites like the colon, small intestine, rectum, and in rare cases we can see the GIST outlining around the peritoneum, the mesentery, or the omentum. I'll split the GIST locations by gastric or non-gastric, because you will see in a while why that's important. In terms of metastatic sites, the most common metastatic sites would be the liver and the peritoneum. You can see odd locations for metastatic sites like lymph nodes, bone, or even lung. GIST accounts for approximately 20% of the soft tissue sarcoma cases, because we would put GIST into the soft tissue sarcoma family. There are approximately 800 to 900, I've over-exaggerated a bit with 1,000, in between 800 and 900 new cases per year. And out of these cases, what I can tell you is that up to 10-20% are diagnosed at a metastatic or advanced stage. So 80% would be localized, and 20% will be 80% will be localized, 20% would be locally advanced or metastatic. In terms of molecular alterations, as you might know already, the most common mutations that we see in GIST are the c-KIT mutation and the PDGFR-A mutation. c-KIT comprises of approximately 80% of the cases, whereas the PDGFR-A accounts for 10-15% of the cases. The rest would be classified as wild type KIT PDGFR-A GISTs. In that category, we'll have the SDH deficient and SDH, so SDH deficient and non-deficient. In the non-deficient SDH, we'll see the BRAF mutation, the KRAS, NTRK, NF1 mutation. In terms of the most common GIST, the KIT mutated GIST, it's important for you to know is that in up to 80% of the cases we'll see an exon 11 mutation, which tends to be quite sensitive to imatinib, whereas the exon 9 mutation, which is the second most common KIT mutation, which is seen in up to 10% of the cases, is not that sensitive. Sometimes you might need like a more intensive imatinib treatment for it. Exon 13, 14, 17, 18 are quite rare for primary GIST. You will get a lot of exon 17 and 18 as part of the resistant mechanism for imatinib. In terms of PDGFR mutation, we can see, or most of the cases are an exon 18. 65% of exon 18 are the D842V mutation, which is resistant to imatinib, and usually the rest non-D842V mutations tends to be responsive to imatinib. Also important to mention is that these wild-type KIT PDGFRA mutations tends to be resistant, not that sensitive to imatinib. 5% of the cases that we see in the GIST populations are associated with a genetic condition. These are the 4 more common and the only 4 genetic diseases that are associated with GIST. What I can tell you, I'm not gonna take it separately. The only thing that I'll say is that up to 80% of these genetic related GIST patients are young patients, and a lot of them won't have the KIT mutation, and the PDGFRA mutation is just the familial GIST that will end up having a germline mutation in respect to the KIT and the PDGFRA mutation. Going to the main part of my presentation, the MDT meeting process in the GIST population. What's MDT? MDT stands for multidisciplinary team, and this multidisciplinary team, the role of the multidisciplinary team would be to provide the best outcome of the GIST patient and any other patients in any other cancer, because the MDT is like an essential part of every cancer nowadays. And the focus, the MDT process, I'll split into 2 parts because I think that's very important for you to know, is the MDT focus on localized disease and MDT focus on locally advanced metastatic disease. And there, in the locally advanced metastatic, we have the subset of patients that are imatinib sensitive, and we have the subset of patients that won't be imatinib sensitive, which is important as well. So in terms of the MDT focus, we focus on diagnosis and staging, we focus on re-stratification, we focus on best surgical decision making process, we focus on the treatment planning, and we focus on the surveillance and follow-up schedule. Which are the members of the MDT that are like an active part in the GIST? Are the surgeons, the medical oncologists, the radiologists, pathologists, genetician, nurse specialist, and here I would like to thank Charlotte, who's a critical and essential part of our team. Thank you, Charlotte. The gastroenterologist, and sometimes the palliative care and supportive care services. We tend to do a separate MDT with the palliative care and supportive care. If the patient needs support from that perspective, we will directly refer to them and we will directly discuss with them their issues rather than them being into this big MDT. In Greater Manchester area, we have 2 main MDT meetings. One is the weekly meeting that involves all Greater Manchester and Oswestry, which is held every Wednesday afternoon. And the other one is the Christie-based one, which is, again, a Wednesday, but pre-lunch. Going back to the main focus of the MDT meeting is the diagnosis and staging. Basically, the diagnosis and the staging, the diagnosis is done by biopsy. Biopsy would say exactly the type of GIST and all the features, the risk features. But in terms of staging, we tend to use the AGCC 8th edition criteria. And this is like the TNM staging of the GIST, and this will be the same for the gastric and non-gastric GIST. What I can tell you is quite rare to see lymph node involvement. Usually the lymph node involvement is more present in the SDH population, positive population. Going forward, the staging criteria is important. The staging criteria is important because it will separate the GIST and the non-GIST. The gastric and the non-gastric GISTs. And what we can see here, for example, for a T3, primary tumor T3, N0, M0 with a high number of mitosis and a high risk, the patients will be classified as a 3B, whereas, for example, for a T3 gastric N0, M0, again high, it's a 3A. Also, in terms of the risk of relapse. Yes, so going back to this, the T is the primary tumor. Based on this criteria, we have from Tx, which the tumor, primary tumor cannot be assessed, to, like, let's say T3. The primary tumor measures in between 5 centimeters and 10 centimeters in size, whereas CT4 means that the primary tumor, the primary GIST, measures more than 10 centimeters. The acronym in front of T, the C, means clinical staging, which means that we'll do this based on the imaging, whereas the P means pathological, which means that the staging will be done after surgery. So a T3 in between 5 and 10, N0, M0 is 3B, for example, for non-gastric GIST, whereas a T3 in between 5 and 10 centimeters, N0, M0 for a gastric GIST is 3A. Why is this important? Because the risk of relapse of a small bowel or non-gastric GIST is way higher than for the gastric GIST in the intermediate group. So the intermediate gastric GIST group tends to have a very low risk of relapse, whereas the similar pattern of a non-gastric GIST, which would be classified as high in this setting, has a very high risk of relapse. So if we have a small tumor with high number of mitosis, that means in gastric GIST that we have like an intermediate risk of relapse, whereas if we have a small tumor with a large number of, or like a high number of mitosis in a non-gastric GIST, we have a high risk automatically. So this is very important because... Can you explain what mitosis is? Yes. So yeah, I'll explain, because the next slide will be the risk stratification criteria that we tend to use as part of the MDT process in GIST, and we have two main scores. This is the AFAP score, or also known as Lassota-Miettinen score, risk classification score, and as we've discussed previously, or as I said previously, the mitotic rate is quite important. So the mitotic rate is the number of rapid proliferation that we tend to see on the surgical or biopsy specimen. Usually we take into consideration the surgical specimen, and on that specimen we see how rapid those abnormal GIST cells are replicate and are multiplicating. And if we see less than 5 number of mitosis per 50 high power field area, then it means that the GIST is not that aggressive. There are not a lot of abnormal replicative processes within the tumor specimen, whereas if the number of mitosis are more than 5, that's like a risk factor for relapse, and that will classify and stratify patients. So when we take into consideration the risk factors for a GIST patient, we take into consideration the dimension, and the threshold for dimension would be 2 centimeters, so 2 centimeters, 5 centimeters, and 10 centimeters. We'll take into consideration the number of mitosis based on this risk stratification score, the Lassota-Miettinen risk stratification criteria. And this will classify the GISTs based on these features. So for example, a gastric GIST, which was 7 centimeters in size and had a low mitosis rate, would be classified as a low GIST, low-grade GIST, which means that there's a low risk of relapse, and if we transpose into percentage, the risk of relapse is very small. So relapse-free survival, which means that the patients won't end up having a relapse, is more than 95%. So 96% of the patients won't relapse if they are classified as, for example, low-risk gastric GIST. Whereas you can see already there's a difference. For example, a non-gastric GIST with a small number of mitosis, but a big dimension would be classified as intermediate. And also, if it's above 10 centimeters, it will go automatically to the high-risk classification. So they will need adjuvant imatinib if they are a KIT mutant or PDGFR non-DV842V mutant. So this, yes. Yes. So this was the risk of relapse at 1 year, but also the risks are quite low after 5 years and 10 years for the very low and low population.
Can I just ask as well, are all these relapse rates, that's without taking treatments into account? So if you suddenly got a imatinib, which all changed.
Exactly. You are completely. Yes, exactly. So these are figures without imatinib treatment. That's why we need these scores in order to stratify the patients to help them with imatinib if possible, because some patients won't benefit from adjuvant treatment. It will be a little bit later in my presentation which subset will be.
Can I ask a question?
Yes.
So when you're looking at the stratification, do you take into account if, for instance, the tumour had ruptured or obviously that it created a burst?
So it's a very good question, and my next slide will be about that.
I wasn't looking ahead.
Yeah, no worries. So we've discussed about the Lassota-Miettinen classification, and I'll go to the next classification, which is the NIH classification, also known as Fletcher. And this was updated, as you can see, in 2008, and the update was about tumor rupture. Tumor rupture, we consider it to be a poor prognostic factor, so we would be inclined to give adjuvant imatinib in this subset of patients because we think tumor rupture is a risk, gives you an extra risk or a very high risk of disease relapse after surgery. In terms of classification, this is much more the same as the Lassota-Miettinen. It's just this tumor rupture that has been included, and as I said, it's part of the MDT process and the discussion and the stratifications of the patients. Yes?
Right, yeah, I've just been told off by the audio guys. If we want to speak, can we get a microphone to you first, please?
Hi. Is that working?
Yes.
Yep, good. You gave the percentage before imatinib. Do you have statistics which tell us, in fact, how that percentage reduces, for instance, after taking imatinib at 1 year, 2 years, 3 years?
Yes. So what I don't know out of my mind the exact figures, but what I can tell you that is that the imatinib in the adjuvant setting for high-risk GIST will reduce the risk of relapse by more than 20%. Going back to the MDT process, the treatment planning, which is a very important aspect of the MDT process. So the treatment, there is a consensus to avoid imatinib in wild-type KIT PDGFR-A population. Because those subset of patients won't be sensitive to imatinib, so then we have to consider the risks, benefits, the side effects, and everything when we do that. So I wouldn't consider imatinib in that setting. Also, for low-risk GIST that weren't amendable for radical surgery, R0 means that the surgery was done with clear margins. So if the surgery was done with microscopic positive margins, for low-risk population, you can consider leaving it like that. You don't need to do a re-resection. You don't need to do adjuvant treatment. So this is an important aspect that is discussed in the MDT meeting.
Can you just explain what you mean by adjuvant?
Because again,
Yes.
I'm sure there are people that wonder what that means.
Okay, so adjuvant treatment means that once you had surgery for your GIST, we will give you, as medical oncologists, will give you adjuvant treatment, which means that we will help you with your disease and we will try to reduce that risk of relapse. So adjuvant treatment means helping your disease not to come back, basically. And also we have the neoadjuvant setting, which I'll discuss later on. So in terms of the surgery is the mainstay in treatment in the GIST population. There are some rare cases that won't be amendable for surgery directly, and those cases needs to be clearly discussed in the MDT meeting because there might be a role for neoadjuvant imatinib. Neoadjuvant imatinib is given only for imatinib sensitive patients, so the subset of patients with the KIT mutation and the subset of patients with PDGFRA mutation non-exon 18 D842V mutation. For that, avapritinib might have a role, but currently avapritinib is not approved in the UK.
We're working on that.
And I really hope you will get it, because avapritinib tends to be quite good in the locally advanced metastatic GIST that is PDGFRA D842V mutated. From statistics, they say that more than 70% of the patients will be progression-free at 1 year, which means that they won't progress at 1 year with avapritinib in this subset. So I really hope you'll get that. Yes, going back to my presentation, if the patient is not amendable for surgery in the first instance, the MDT will discuss what's the role of neoadjuvant imatinib. Neoadjuvant is helping the surgeons to reduce the tumor burden and the tumor dimension in order to achieve a better surgery. And what I can tell you based on quite recent data from ESMO is that for non-gastric GIST, mainly esophageal GIST, rectum GIST, duodenal GIST, the neoadjuvant treatment has a role because it will create a more limited surgery rather than an extensive surgery. Because, for example, for duodenal GIST, you don't want to do a duodenopancreatectomy, which means you will remove the duodenum and a part of the pancreas. With the surgery, you will try to limit that resection if possible, and imatinib can do that. Okay, going to the next slide, which is the surgical decision. As I say, surgery is the mainstay of treatment. Surgery should be recommended for localized GIST, even in the non-KIT PDGFR population. Usually that subset of patients, the wild-type KIT PDGFRA, would have like a very slow low progressive GIST, will be multifocal, so it might be quite tricky to do surgery for them. And for them, sometimes active surveillance and watchful waiting approach is a consensus and a recommendation within the MDT meeting. Also, in terms of the surgical, as we've discussed already, what we want to do with imatinib is to transform an unresectable or a very mutilating surgery into a more limited surgery, and we tend to do that. And also the aim of this neoadjuvant approach and surgery after imatinib is to reduce the surgical morbidity and some permanent functional disabilities that you guys might have if surgery is done if surgery is the first step into treatment. Also, what I can tell you, the duration of neoadjuvant treatment in this setting is usually in between 3 and 12 months, because from our experience, we've noticed that there will be a maximum response around 6 to 9 months on imatinib, and then we will rediscuss the case in the MDT. We will say from our end, and as medical oncologists, we've achieved the maximum response in this neoadjuvant setting, and now surgery would be the option. And in most of the cases, if that happens, the patient will go for surgery, and afterwards he will come back, and based on tumor features and risk features, we will decide if we go or not with further adjuvant imatinib. Why I say that is because sometimes we tend to decide upon neoadjuvant treatment for big GISTs, so like massive tumors that are more than 10 centimeters in size, in order to reduce them. And then in the end, once we have the pathology report, we will see that those GISTs are not that aggressive. They will be classified as intermediate or low risk, even though they were quite high at the beginning. So that's the moment when we decide, okay, we won't carry on with imatinib anymore. In terms of adjuvant treatment, if we started the neoadjuvant treatment as part of patient's strategy, we will carry on with neoadjuvant, as I said, in between 3 and 12 months. Then the patient will have surgery. Then if the patient is if the patient will need further imatinib, then we'll carry on with adjuvant imatinib up to 3 years. So it's not 3 years from the moment he had surgery, is 3 years from the moment he started imatinib, even in the neoadjuvant setting. So after surgery, you might have only 15 months left of imatinib. It's not necessarily you'll need 36 months. Okay, so this is the ESMO, which is the European Society Medical Oncology Society for Medical Oncology. This is like the recommendation for localized GIST with imatinib sensitive mutation. So if it's if you can achieve an R0 surgery with no expected major sequelae, then you go directly for surgery. Whereas if you have an R0 surgery but with expected complication, comorbidities, if the surgery is mutilating, we would recommend preoperative imatinib for 3 to 12 months. In the setting of, as I said, in the setting of patients that had neoadjuvant imatinib, if they will reach most of them would reach the R0, R1 resection. So most of them will be feasible for this, and they'll go for surgery. Tiny subset of patients might not be feasible for this, and then we'll go to the locally advanced or metastatic GIST recommendation for them, which I'll discuss later. As I said, for low intermediate risk, the recommendation would be follow-up. And for high-risk GIST, gastric, non-gastric, the recommendation would be adjuvant imatinib for 36 months. As I said, 36 months needs to be with the neoadjuvant and adjuvant if the patient was on neoadjuvant approach. Last part of the MDT process, which implies localized GIST, is the surveillance and follow-up, which is very important because once you've completed adjuvant imatinib, you need to continue under close surveillance for a while, and then depending on the years that have passed since you've had the adjuvant treatment, we will extend those follow-ups. And the tricky part will come when a CT scan is done, and that CT scan shows some equivocal imaging while on follow-up. That equivocal imaging could be a thickening, could be a completely independent finding from the GIST, or it could be a local relapse. And this needs to be clearly discussed in the MDT. The radiologist should have their clear input, and usually if we have clear signs of disease relapse, probably the recommendation within the MDT process for this population would be to restart imatinib if patients were on follow-up program, whereas if patients are having only like a tiny thickening or a tiny nodule, we might offer early scan interval, which means that we will carry on with surveillance and we will see in dynamic what will happen with that nodule. Going to the advanced metastatic GIST, which can be quite burden for the patient, and it can be quite traumatizing for the patient. The MDT role in this setting is more critical, because here, if you try to do radical approaches, those more radical approaches might not help the patients, and that's why we need to stratify which patient will benefit from these radical approaches in the advanced or metastatic setting. So we need to assess the oligometastatic versus widespread disease. Oligometastatic means that the disease, even though it has been diagnosed as metastatic, has only few sites present, usually would be confined to only one organ. So for example, let's say liver, and usually will have less or maximum 5 lesions. So maximum 5 lesions, only one organ is considered to be oligometastatic. Whereas if the patient has multifocal or widespread disease, that means that they have multiple liver lesions, they might have some peritoneal lesions as well, they might have some omental mesentery lesions. So we need to do the clear stratification in between these two categories of metastatic or advanced GIST. And then we need to see clearly from those patients who are oligometastatic, because that would be the subset of patients that would be amendable for more radical approaches, which patients are good candidates for radical approaches, more radical approaches, and which are not. So we need to clearly and carefully evaluate each patient and each patient's status, comorbidities, and so on. So one radical approach in terms of metastatic GIST would be the metastasectomy, which will be mainly in localized disease, mainly for liver lesions, but this can be done even for peritoneal lesions or mesenteric lesions if, again, these lesions are isolated, confined around a certain area, are not dispersed or multifocal all over the abdomen. Also, there's the possibility, for example, for a liver lesion, if we have, for example, a patient who has 4 liver metastases, out of those 4 liver metastases, 3 are responding to imatinib, 1 is not responding to imatinib, 1 is showing signs of progression, then that lesion might be amendable for a more radical approach. Same thing for peritoneal deposits. In terms of metastasectomy for liver, there are like different types of metastasectomy procedures, and I've included them here. What you need to know, even though it's a quite mutilating surgery, the liver metastasectomy, if we leave in place 30% of the liver parenchyma, then that should be fine. So you can have like an extensive liver surgery if the disease is controlled on imatinib. If we see only a site of the disease that's progressing, then maybe we can offer like a more radical approach in terms of all the liver lesions, and the surgeons might say we will do like a segmentectomy, for example, or a left hepatectomy. It varies. Where's the location of the tumor, how big is the disease burden within the liver, and so on. There is no benefit. What I can tell you is that there is no benefit of surgery if the disease is progressing. If the disease is not progressing and the patient is amendable for a radical approach in this setting, in the locally advanced metastatic setting, what I can tell you is that we've seen better outcomes. So in terms of overall survival, progression-free survivals data, patients who were eligible and amendable for radical approaches have a better outcome than patients that continue just on imatinib. But again, we need a clear stratification of these patients, because this subset of patients would be like a quite small proportion. Next, local therapies. Local therapies, I would say, are mainly for liver diseases. So if you have like a liver met, again, that is further progressing, whereas the rest of the liver mets are stable, the MDT consensus might be for a local ablative therapy, and the ablation could be usually via radiofrequency or chemoembolization. Radiofrequency is a form of thermal ablation, whereas chemoembolization would be a form of intra-arterial chemotherapy.
Sorry, just a quick question. So these type of radiotherapy or embolizations, why are they only limited to the liver? So why is it that they would only work in the liver and not work in some of the other organs?
That's a good question. So because liver is like a, how to say, a solid structure, like has a parenchyma, it will be, liver would be amendable for these radical approaches, because if you do it within the peritoneum or within the mesentery or the omentum, you might cause more harm with this procedure. So these procedures are not that safe in the other population, apart from the liver-related metastatic GIST population. So if you have liver mets, if the liver mets are responding to imatinib, but there's 1 or 2 or 3 that are not responding, if those lesions are around 3 centimeters in size, those lesions might be amendable for this approach. So the threshold is usually less than 5 lesions, and the dimension is around 3 centimeters of the lesion to be amendable for these approaches. And one is a thermal approach. Thermal approach means that they will use heat in order to kill that nodule, and the embolization process implies chemotherapy directed directly into the tumor via intra-arterial pathway, and I'll show it to you here. So basically the chemoembolization, we'll have to put a catheter, but usually this is done by interventional radiologists, gastroenterologists. So they put a catheter in, that catheter will go directly into the hepatic artery, because we know for a fact liver lesions are nurtured by the arterial flow. And they will give like a dose of chemotherapy around this area, and once we give the dose of chemotherapy around the nodule, they will use like an embolization patch. They tend to use like a gel foam, which will basically block the vessel, and it will help the chemotherapy drug to stick into this area that's close, and it's like helping and feeding the actual nodule. Radiation therapy in GIST, I left it as a last option, is not that effective. So what I can tell you is that GIST is a radio-resistant tumor, tends not to respond well to radiotherapy, but radiotherapy could be an option in certain situations. For example, patients who have like a massive tumor that's causing an invasion into their bladder, and the bladder secondary to that is causing hematuria, like blood in the urine. So radiotherapy might be an effective option in order to stop the bleeding. So it can have hemostatic purposes, it can have palliative purposes. If you have a massive tumor that's causing any sorts of pain, you might give radiotherapy in order to help with the pain. And what I can tell you for palliation like this, like hemostatic purpose, pain purpose, radiotherapy can help quite a bit. Also, an important aspect, everything that I've discussed so far in terms of radical approaches was for metastatic GIST imatinib sensitive patients, so patients who have a locally advanced metastatic or relapsed disease and are sensitive to re-challenging imatinib in this setting. If they respond to imatinib, but we see like a sign of early progression, these radical approaches would be a good option for them, and these approaches would be discussed in the MDT. The role of these radical approaches in second, third line patients are not that well defined, but they still have a role. So even though the patient is on second line sunitinib or third line regorafenib, if we've reached a good response, a good stability of the disease, because most of the time with sunitinib and regorafenib will see stable appearances, we can discuss with the patients the purpose and the role of surgery. But in this setting, surgery might be more tricky than in the imatinib sensitive setting, because for second line, third line GIST, we know for a fact that these tumors tend to be more aggressive than for imatinib. So the disease might come back more rapid. The disease might be more aggressive if we do surgery. So that's when we'll have to clearly say exactly which is the subset of patients that will benefit from this surgery in the third line and second line setting. Also, what I can tell you, if a patient is diagnosed with a relapsed disease, if the disease is amendable for surgery, if the patient is imatinib sensitive, the first instance would be to start imatinib in this setting. And our recommendation would be, even though you had radical resection of the relapsed disease, is to continue on indefinite basis with imatinib, because we've seen that patients who had the disease relapsed and stopped imatinib have had worse outcomes than patients who had the disease relapsed and stayed on imatinib. And usually imatinib is like part of someone's life. I can see in the audience patients who've been on imatinib for more than a decade now. So even though it might be a burden for you to consider imatinib on long term, imatinib, if it's tolerable, is like it's similar to like a blood pressure tablet. That's what I usually say to the patients if the disease is controlled and they have to take imatinib for a long period of time. And the last part of the MDT process would imply the discussion and feasibility of patients to enter into a clinical trial, because the clinical trial is an essential part of our practice. And clinical trials, as you might see here in this slide, are three main types: phase 1, phase 2, phase 3. Depending on number of patients, depending on multiple factors. So this needs to be discussed with patients who will progress on imatinib. So a good recommendation would be to discuss nowadays with patients, once they've progressed on first line imatinib, to consider second line a trial option rather than sunitinib. Because I'll go next in the updates. In my last part of the presentation will imply these updates on clinical trials in GIST. I focused on UK-based trials, but I've included some international trials as well. The most important trial nowadays in the GIST population in the UK is the INSIGHT trial. And the INSIGHT trial is still recruiting patients. The INSIGHT trial is a phase 3 clinical trial, which is open label, and the stratification of patients will be done based on their resistant mutation. So a lot of patients on imatinib, if they develop progression, they will develop an exon 17 or 18 mutation. So the stratification within this trial will imply, so first line imatinib, they are progressing on imatinib, and second line would be consideration of this trial. Patients will be tested, and if they have the KIT exon 11, which is the most common mutation in KIT, plus 17 or 18, the resistant mechanism mutation, they will be assigned to the ripretinib arm, because what early data says is that these patients that have this mechanism mutation, mechanism resistant mutation, exon 17 and 18, will respond quite well. So there will be a massive difference in between ripretinib responders and sunitinib responders in this population. So roughly the median progression-free survival will be bigger by more than 10 months in the ripretinib population. So this is a good trial that needs to be considered, and it's still recruiting patients. Currently, as far as I'm aware, is recruiting in Leeds. So close to Manchester is Leeds and London. Another trial that we have currently in our clinic is the PEAK trial. The PEAK trial, what I can tell you, is still recruiting patients, but I've checked yesterday, and in the UK it's active but not recruiting, so they've stopped the recruitment. And the PEAK trial will imply phase 3. Currently is the part 2, which is phase 3 trial, and will imply 2 arms. It's an open label. It will be sunitinib versus sunitinib plus bezuclastinib. Bezuclastinib is a similar TKI drug, like a very potent drug that tends to add some effect to the sunitinib. And the important aspect within PEAK trial is that if the patient is assigned to the control arm, which is the sunitinib arm, once they've progressed, they can go into the experimental arm. They can cross over to sunitinib plus bezuclastinib. Another interesting trial, but this is a phase 1 trial, and this is currently only in London, is the Strategist 1 trial. Currently is just assessing the safety, tolerability, and the effective dose of this drug called IDRX42, which is again a small pan-TKI inhibitor. Pan-TKI means that it will block multiple tyrosine kinases, which are the main responsible for GIST development. And based on provisional data, the objective response rate for that tiny subset of patients that has been on this was quite good. It was around 40%. MK64820015 trial. This will be mainly for the wild-type GIST population, so wild-type KIT PDGFR population. This trial will have multiple cohorts, including non-GIST patients, but the one cohort, which is cohort C, will imply GIST patients, which are SDH deficient, because by definition, SDH is an enzyme that will, if it's deficient, will cause an overexpression of this HIF, which is hypoxia-inducible factor. So the rationale would be, if you block the SDH, you'll block the. If you block the HIF, you'll block basically the development of these SDH deficient GISTs. And the drug that is tested is called belzutifan, a drug that has already been approved, for example, in renal cancer, with this overexpression of HIF, or with a germline mutation called VHL. Another interesting trial, the MK, as far as I know, is not in the UK. Atezogist as well is not in the UK, unfortunately, is in France, multiple locations, still recruiting patients. This is an interesting approach. So atezogist would be 2 trial arms, will imply patients that have progressed on imatinib, sunitinib, and regorafenib, and then the rationale to re-challenge imatinib, because you might find some tiny subclones that might be responsive to imatinib. And the trial implies immunotherapy, atezolizumab, plus imatinib, same dose. Atezo would be given as an IV drip every 3 weeks, versus re-challenge imatinib only. And this is recruiting in France currently. the AMC 2203 trial, unfortunately not in Europe, it's just in, I think, Korea, but it's interesting because it's again for a rare population of GIST, which is the SDH deficient GIST, and it will check, or it will see the role of temozolomide. Temozolomide is an alkylating agent. Basically, temozolomide is a chemotherapy drug. So they are assessing the role of chemotherapy in the subset of patients with SDH deficient GIST. And one of the last trials that I've mentioned here is NCI 2023-08857. Again, this will be for specific subset of patients with exon 14, 17, 18 resistant mutations after imatinib and SDH deficient, and they will evaluate the role of regorafenib in this setting for second line post-imatinib. The last slide, my last slide, will be about Target National Trial, which is an early phase multinational trial that will assess basically the molecular patterns of different solid tumors. And in this trial, GIST patients are welcomed as well. What they are gonna do, and what they are doing, they are trying to recruit 6,000 patients. And what they are gonna do, they are gonna stratify the patients. So nowadays, we tend to refer some patients to the early phase clinical trial for consideration of this. We will do a referral letter. The early phase clinical trial team will see the patients, and they will decide if the patient is fit, if the patient is a good candidate. If they decide the patient is fit, is a good candidate for this trial, they will go with tests, and they do blood sample biopsy. So they can do liquid biopsy or tumor-based biopsy. Liquid, most of the cases, liquid biopsy. In that liquid biopsy, they will try to find circulating tumor DNA. And if they find a circulating tumor DNA, they will find any potential molecular abnormalities that have triggered the GIST, or that have triggered the resistance to imatinib or to these previous treatments. And if the patient has a targetable mutation that is found in this liquid or tissue-based biopsy, they will go basically in this virtual national molecular tumor board. This will be discussed in an MDT meeting separate from ours. And then if the patient matched a potential molecular-based target, they will go directly into that targeted treatment approach, regardless of their tumor, regardless of their tumor. So you can have hypothetical mutation in GIST, and you'll have the same mutation in another type. You will be amendable for that targetable treatment, regardless of your tumor type. Thank you.